Moving on to headaches. For this, I would like to invite Dr. Dinesh Lokhande. He's MBBS DTCD, FICM, IDCC. He's a pulmonologist practicing at Health Plus Nursing Home since 23 years. As a physician, he has seen all types of headache, including me, literally and figuratively. And he takes time to listen, diagnose and treat each one of them with kindness and expertise. And I would also like to invite Dr. Sham Ichur. He's BMS practicing at SUS since 15 years as family physician. He's a sports enthusiast and is a captain of first BMA cricket tournament winner team. Wow, congratulations, sir, for keeping your passions alive.
Thank you. Welcome Dr. Priyanka Walzade, Tonde ma'am. She is MD Medicine from BJ Medical College, Pune. DM Neurology from SET GSMC Hospital, Mumbai. She is a consultant at Medipoint Hospital, Jupiter Hospital, AIMS Hospital, and Lime Point Hospital. And she has a clinic, Dr. Tonde's Neuro and Ortho Clinic, Baner. She has a special interest in epilepsy, headache, and vertigo. Over to Dr. Priyanka.
Hello everyone. I thank BMA and all BMA committee members to give this opportunity to present the talk. So before starting the lecture, I want to clear few things that this lecture is not about covering the theoretical part and classifications and all the material which is easily available in all the textbooks. But this mainly aims at approaching a headache patient when any patient comes with the headache and stressing on some important points which we should definitely look and ask when a headache patient comes. So as we all know, headache is an extremely common symptom in neurology and even in the general practice. We can say that one of the commonest symptom in whole medicine. So headache can be described in different ways. So we can see as headache, head heaviness, head tingling, sharp shooting pains in the head, neck pain which goes to the head, and many patients say this also, that gas goes to the head, bursting in the head. In Marathi they frequently say that डोकं जड वाटतंय, डोक्यात मुंग्या येतायत, माझा गॅस डोक्यामध्ये जातो, डोकं फुटल्यासारखं वाटतं. So these are the various complaints we listen very frequently, and sometimes we don't know what to do with them because they are so disabled. It is a wastage of their working hours, productivity. They are really disturbed with all these symptoms, and then what to do further. So we are going to discuss what to do with all these patients, how to approach them perfectly without advising very costly investigations, and how to make them symptom free. So why headaches are important? So first and foremost, very common symptom. Almost all of us also must have got one headache at least in our lives. So it is extremely common. A high morbidity, loss of efficacy, and decrease in the quality of life. It is a big loss of working hours. Many patients tell us that I am not going to the office, I am not able to perform my daily activities due to the headaches. So if we miss the type of the headache, we don't go into details of the history and we don't diagnose the headache properly, what it does is patient keeps taking the painkillers, they keep doing multiple MRIs. I have seen patients who have done one MRI every year for the headache. So it is very important that we diagnose the headache properly, what is the type, and we treat it properly. Second is that medication overuse headaches are very common. There is something called as medication overuse headache. If patient keeps taking painkiller, it again propagates the headache and in turn it increases the headache. So more analgesics, more headaches, and this circuit propagates. So what should we do when patient comes to us? So should I just give a short course of analgesic and assure the patient, you take this medicine for 5 days, you will be fine? Should I do the brain imaging so I'll not miss anything and I'll be safe? Just every headache patient, let's advise CT or MRI. It is normal, so we can tell the patient, see, your brain is normal, now don't do anything, it is normal. Or I should not do anything, I should just counsel the patient, kuch nahi, headache hai, aap medicine le lo, chala jayega, don't worry about it. So if we do any three of it, what happens is patient keeps coming again and again. They are not happy because they are still getting the headache. CT or MRI is normal, it is not going to cure their headache. or even if we assure them ki he kai serious nahi hai, it's okay, they are having headache, it is a big morbidity, they are wasting their time, so they'll keep coming, they'll keep taking painkillers, and eventually all these options are not going to solve the problem. So only thing that really helps in the headache management is history, history and history. Because out of 100 patients, 99 patients of headache are going to have normal MRI and CT brain. So 99% of the headaches are non-structural headache, in whom imaging is going to be normal. Only 1% patients will have abnormal imaging. So most common type of headaches have normal brain MRI and CT scan. So we need to ask very much in detail about the history. So what further details we should ask in a headache patient? So first and foremost question which everyone should ask for any person who has headache is, since how many years you have headache, or since when the headache is started. Whether it is a new onset headache or you had such headaches in the past. So we have to delineate exact pattern of the headache. Patient will always say, I have headache since 5 days. But we have to ask, did you have any headache last year? Did you have any headache last month? How many headaches in last 6 months? Whether it is like headache comes for 15 days, then for a year you are headache free, and then next year you are again having headache for few days. What is the exact pattern and frequency of headache, and whether it is a new headache, this headache has never happened, or whether it is an old headache which is increasing. So this is extremely important in any headache patient. Whenever the patient comes to us in the clinic, we have to differentiate whether it is a primary headache or secondary headache. So primary headache is just a headache, it is nothing else. Primary headache doesn't warrant any investigation, and it is not related to the structural problem in the brain. And secondary headache is something that it is structural. There is some clot in the brain, bleeding in the brain, tumor in the brain. So clinically, when we see the patient, we need to differentiate whether it is primary headache or secondary headache. This is the first base of the treating headache. So primary headaches can be attributed, are not attributed to any other disorder or cause, and they are just headaches. So what are the red flags in the headache which will tell us that it is not a primary headache? So whenever patient tells us about some symptoms, we have to become alert that it is not a usual headache and it is something different, and we have to go ahead with the investigation. As I told you, these patients are just 1%. 99% of the headaches are generally primary headaches. They are, we can say that this is a tendency of the brain, and they keep getting headaches intermittently. So first is acute onset headache. The headache which has happened suddenly, or it has happened recently, that I have headache since 1 month, I never had headache in past, that is very severe, it is disturbing the daily activities, it is making patient to sit at home. This is acute onset and very severe headache is the first red flag that it is not a usual headache and we need to work up further. Second is severity. Now generally what patients say in a primary headache or usual headaches is, I have headache but I still go to the office. I have headache but still I cook. I have headache but I can do all my daily activities. So when patient says that since 2 days I have a headache and I am not able to do anything, I am just at home and I am not able to perform my routine activities. So that is a red flag. Third is start to peak duration. So the question we have to ask is, when you feel that you are going to have the headache, and after that when there is maximum severe headache, what is the duration? So headache is increasing over few hours, few minutes, or it is just sudden. So when onset to peak duration is very small, patient says that की मला एकदम severe headache होतं, 5 ते 10 मिनिटात इतकं severe होतं की I can't do anything. So this is onset to peak is very short. That is one of the red flags. जनरली सकाळपासून थोडं थोडं हेडेक सुरू होतं, दुपारपर्यंत वाढतं, संध्याकाळी जास्त होतं. This is onset to peak is not very fast, it is slow. So when onset of headache to peak of headache is very short, it is one of the red flags. Next is associated symptoms. So in a headache patient, if there is anything except headache, multiple vomitings, blurred vision, double vision, tingling in hand, any other symptom except headache, then we have to be alert. And last is examination. So if a patient comes with headache and right upper limb weakness, headache and blurred vision, headache and double vision, there is a squint, then obviously this is not a primary headache and it needs further imaging. So first, always differentiate between primary headache and secondary headache. So here we come to case 1 to understand this concept better. So he is a 28 years old male, came with history of headache since 7 days. So now patient will always say, I have headache since 7 days. But we need to go in depth, we need to ask him details. So as I told you, first question we will ask is, did you have any headaches in the past? Or is this a first headache in your life? So patient's answer is, I had headaches in the past, but it was not so severe. But every month I used to get 2 to 3 headaches, but now since 7 days it is very severe. So this patient will tell only if we are asking. Otherwise, patient always says, I have headache since 7 days, it is very severe. So we have to go in depth in the history that did you have any headache in the past. So next question should be how severe it is. Are you not going to office or you have stopped your household work? So patient says, no, I am going to the office, but post afternoon I get headaches. It is starting slowly, it increases over 4 to 5 hours and then it becomes severe. So next question will be, in last 7 days, you are having daily headache for 24 hours or it is intermittent. So patient answers, I had headaches for 4 days in last 7 days, I didn't have any headache for 3 days. So all this only if we ask, then they are going to answer. Otherwise they are in headache, they will say, I have severe headache since 7 days. So now you will ask, do you have any other symptoms? Double vision, blurred vision, weakness, tingling, difficulty with walking. Patient says, no, I just have headache. So in nutshell, after taking the history, we have a young male who has intermittent 2 headaches per week since last 2 years. And now he has increased headache since last 7 days without any deficit or without any deficit on examination. So from this description, the likely cause of the headache is this primary headache. It is not something that there is a clot in his brain or there is a bleed in his brain. So in this way we have to delineate whether it is a primary headache or secondary headache, so we can decide whether to advise MRI or CT scan. We cannot advise imaging to every patient and it is not going to help because in 99% it is going to be normal. So once we have reached the conclusion that it is a primary headache, now we have to go in depth which type of primary headache it is, because treatment for every primary headache is different. So there are few important types of primary headaches: migraine, tension type headache. There is one category called as stack headaches, trigeminal autonomic cephalgias, out of which most common are cluster headaches, paroxysmal hemicrania, SUNCT and SUNA. Now why we need to know all these types? Because treatment is different. If we give migraine treatment to a cluster headache patient, he will not recover. If we give migraine treatment to paroxysmal hemicrania patient, he will not recover. So it is very important to know types of the primary headache. So important differentiating point to decide which primary headache is duration of the headache. So we have to ask the patient, once your headache starts, for how much time it lasts. So migraine generally lasts from 4 hours to 72 hours. Tension type headache is also very common type of primary headache, which is 24/7, like for whole day, whole night, whenever patient is awake, he'll feel tightness of the head. Cluster headache is generally 15 to 180 minutes, like 2 to 3 hours, but it comes in the clusters. Like this year, I'll get headache for 20 days. Then for whole year, I'll not get any headache. And next year again, I'll get, or maybe after 2 years, I'll get again 20 days headache. So it comes in the clusters and duration is slightly shorter than the migraine headache. Paroxysmal hemicrania is one of the headaches which occurs multiple times a day. Patient will say, I have a headache. It lasts for 5 minutes, it goes, and I have such 30 to 40 episodes in a day. And SUNCT and SUNA are the shortest lasting headache. माझ्या डोक्यात चमक येते, 2 मिनिट राहते आणि 50 ते 100 वेळा दिवसात मला असं होतं. This is short lasting headaches. So few important features to ask between, to differentiate between the headache types. So we all know that photophobia, difficulty with light, phonophobia, difficulty with loud sound, nausea, feeling of vomiting or vomiting, and headache goes away with sleeping. I am completely fine if I sleep for 1 hour. All these are features of migraine. But photophobia and phonophobia don't diagnose the migraine, because in other headaches also photophobia and phonophobia is very common. So just photophobia and phonophobia will not say that this is the migraine, but we have to look into other aspects also, that what is the duration of the headache, what are associated symptoms. So two symptoms I want everyone to ask for a patient with primary headache is whether you are having any tearing from eye during the headache, and where eye goes red, redness of the eye. Because in the headache classification, as I told you, this TAC type of headache, trigeminal autonomic cephalalgias, they have completely different treatment, and classic of TAC headaches is that either they have tearing from the eye or their eye goes red during the headache. So these are the two symptoms we have to ask if patient has tearing from the eye during the headache, and if patient's eye is getting red during the headache, that is not a simple migraine or cluster headache, and this is the trigeminal headache which has completely different treatment, which I will tell you ahead. So if patient has 24-hour band-like sensation, tightness, heaviness and continuous headache, it is tension type headache. There is no episode. कंटिन्युअसली मला डोक्याला बांधल्यासारखं वाटतं किंवा डोकं टाईट वाटतं, दॅट इज टेन्शन टाईप हेडेक. सो नाऊ व्हॉट वी हॅव लर्न्ड टिल नाऊ इज वेदर इट इज प्रायमरी हेडेक और सेकंडरी हेडेक, अँड वी हॅव टू फाइंड आउट विच इज द टाइप ऑफ प्रायमरी हेडेक. नाऊ व्हॉट इज द ट्रीटमेंट? So in migraine, as we all know, if there are more than 2 headaches per week, then we have to give migraine prophylaxis. Migraine prophylaxis are the medicines which need to be taken in a course. Many patients take medicine for 15 days. They say we are fine till we take the medicine. They stop the medicine, then they feel that only when I take the medicine I am okay. So first thing we have to clear to the migraine patient that this is a course. Textbook wise, theoretically it should be given for 6 months. Practically in OPD we give at least for 3 to 4 months. Only if they complete the course of prophylactic medicine, only and only then headache goes away for at least few years. Treatment for 10 days, 15 days, 20 days is not going to work. And 50% treatment is lifestyle changes. So there is a big role of good lifestyle in the migraine treatment. So in cluster headache, indomethacin and high flow oxygen is the treatment for termination of the headache. Cluster headache will not terminate with the naproxen or combiflam or crocin because it is very severe headache and it suddenly increases. So high flow oxygen or the indomethacin is the treatment for termination of the headache. And as we know, tension type headaches, which is the band-like sensation in head, amitriptyline is the drug of choice. However, many studies show that all these migraine, tension type headaches, cluster headaches, they have a big role of stress. So we always have to address the stressors if there are any. If patient is stressed, anxious, overthinking, then the headache medicines will not work properly. So what is the relation between headache and stress and headache with underlying psychiatric disorder? So treatment of headache is not just a treatment of headache. We have to discuss about temperament of the patient, how his day looks like, what is going on in personal and professional life. Many patients with anxiety, depression, OCD reach out for their headaches first. They don't know that they have anxiety or depression or OCD, but they have headaches. So if we go into details of their lifestyle, their stress level, what is going on in their life, then we come to know that probably this patient has anxiety or depression, and until we treat that, headache medicine will not work efficiently. So the treatment of headache also includes treatment of their lifestyle, treatment of their thinking, treatment of their stress levels, and treatment of what is going on in their life at present. So now after discussing about the primary headaches, we will consider secondary headaches. Secondary headache means those headaches which really need urgent investigation, admission and the treatment. Out of total headaches, they contribute 1% of the headaches, but they are extremely important because we cannot miss this. If there is a usual headache, medicine doesn't work, patient will get headache. If we miss the secondary headache, patient will get seizure, patient will get hemiparesis. So it is very important to diagnose the secondary headache. So as I told you, new onset headache, very severe headache, which is disturbing the routine and not responding to the medicine. So what should we do? CT scan or MRI? So CT scan is practically useful only after trauma or in the IC bleed. Most of the CT scan come out to be normal. So investigation of choice for the headache patient is MRI brain plus venogram contrast. So better to avoid CT and directly go for MRI brain and contrast until and unless there is history of road traffic accident or the trauma. So summary, extremely sorry. So there will be, so these are the commonest causes of secondary headaches: cerebral venous sinus thrombosis, subarachnoid hemorrhage, intracranial bleeds, space occupying lesions and infections. So there will be some overlapping cases when we are not able to delineate whether it is just a normal headache or it is really something. The history is not proper, patient is saying very vaguely. So ideal way is give 15 days medicine as per the type of headache and ask the patient if there is no relief in 15 days, then we will do the imaging. Or if you have any new symptom in these 15 days, then we will do the imaging. So in summary, ask a very good history, check for any red flags. Primary headache, ask the details whether it is migraine, whether it is cluster headache or whether it is some other part of the headache. Start the treatment as per the type of the headache. Always ask for the lifestyle, stressors, routine of their day. Involve a psychiatrist whenever it is needed. Secondary headaches, urgent search for the cause, imaging and admission. Treating headache is not just treating a disease, but it's knowing and treating a whole person. Medicines are important as is lifestyle and behavior. Most common cause of untreated headaches is not finding a type of headache. Not going in detail in the history, so type of headache is not known, so treatment is not going on the right track. And second is non-compliance and inadequate duration of the treatment. As I told you, some type of headache may warrant treatment for 3 to 6 months. If we clear them this on first or second visit, they are willing to take it because they are so disabled with the headaches that they want a cure. But if we prescribe for 15 days, then they feel this 15 days and this is done. So counseling about duration and compliance of the treatment is extremely important. Thank you.
Thank you very much, Dr. Priyanka. It is really difficult to finish this topic in 20 minutes, but still you have done a very good job. In today's world of AI and digitalization, we intend to go for more investigations than taking history. And you have very well explained, history taking is really very important. Thank you.
Thank you, Priyanka. May I request the chair to felicitate Priyanka, ma'am. Moving on to the next lecture, Dil Ki Baat.